embolism, the top 10 PE trials. We're talking about diagnosis, massive PE, intermediate risk, catheter-directed. We're going to look at some of the newest guidelines, 2026. So without further ado, okay, so we have the Wells and PIOPED 2. So we're looking back in the Wells and Annals of Internal Medicine 2001, and the PIOPED 2 in 2006. So the Wells score you should definitely know. PE most likely diagnosis gives you 3 points. DVT signs and symptoms positive 3 points. Hemoptysis 1 point. You should just have a general idea. Definitely no alternative diagnosis 3 points. And then the risk threshold less than 4 and then greater than 7. So the understanding the prevalence goes up obviously with the more points that you have. The also you should know the Christopher trial, JAMA 2006. That's where you learn about the D-dimer. Safely rules out PE in Wells less than 4 plus a negative D-dimer. And the PIOPED 2 showed a specificity of CTPA of 96%. That's the standard imaging for PE. And RV to LV ratio greater than 0.9 is a severity marker. So years showed DVT signs plus hemoptysis plus PE most likely reduces CTPA 14%. Validated in pregnancy. We're going to take a look at that. Wells plus D-dimer, the 3-month VTE rate is 0.5% if negative in low risk. And CTPA, no, 96% specific. And the RV-LV ratio greater than 0.9. So again, Wells, D-dimer, CTPA. Okay, so again, you would do the CTPA if you were above 4 points of the Wells criteria, if the D-dimer is positive. Then you have the MAPIT 3. So this is the Constantinides trial, New England Journal of Medicine 2002. So we're looking at massive PE, and the idea is that that's the indication for systemic thrombolysis. Primary endpoint from the alteplase versus heparin alone, 11% versus 25%. And that would be the in-hospital death or hemodynamic escalation. So you should know those numbers, 11% versus 24%. If you just used heparin alone, cardiac arrest, the dose would be 50 milligrams IV push. A full dose is 100 milligrams over 2 hours when not in an arrest. Absolute contraindications, active bleeding, stroke less than 3 months, intracranial neoplasm, recent neurosurgery, severe hypertension. So you should definitely know the thrombolysis contraindications that we just went over. It's a relative contraindication to have a systolic blood pressure greater than 180 over 110. And pregnancy platelet count and INR greater than 1.7. So the teaching for massive PE, systemic thrombolysis, 11% versus 25% when it comes to in-hospital death or hemodynamic escalation. The dose is 100 milligrams over 2 hours. Cardiac arrest, 50 milligrams IV push. And then you have the PEITHO trial, New England Journal of Medicine 2014. We're looking at intermediate risk PE. There they use tenecteplase, 10 seconds infusion over or injection over that 2-hour alteplase. And you could see the primary endpoint, which was death or hemodynamic compensation, was statistically significant, 2.6% versus 5.6%. And this is for normotensive RV dysfunction, elevated troponin patients. But the number needed to treat was 33. The benefit was driven by decreased decompensation, not mortality. And the mortality data, 1.2 versus 1.8%, was actually not significant. The number needed to treat was 33, but the number needed to harm in terms of stroke, intracranial hemorrhage, was 45. And then the major bleeding was NNH was 20. So the NNH was higher than the number needed to treat or lower. So meant that you're more likely to harm. So NNT 33 versus NNH versus NNH of 20. That's the key teaching point. So normotensive patients' bleeding risk outweighed the decompensation benefits. Systemic lysis cannot be used safely in intermediate risk. And this is what drives the entire catheter-directed era, which we're going to get up, which is the HI-PEITHO, which is next. And this is in 2016, HI-PEITHO. CDT cuts composite endpoint 61%. So NNT 16 without the bleeding cost of systemic lysis. So we have, again, intermediate high risk PE, 544 patients. We're looking at catheter-directed therapy plus ecos, which is like an ultrasound breaking up. It was NNT was more than twice as effective as the systemic lysis. There was no excess bleeding. There was objective RV function improvement. And basically, it was low dose local thrombolysis. They put the catheter right into the pulmonary artery and gave about 9 to 18 milligrams versus 100 milligrams. So you get really like 5 to 10 times lower the systemic drug exposure. There was no intracranial hemorrhage. And so that was good. So then this had to be a patient not in shock, RV-LV ratio greater than 1 on a CT scan, elevated troponin, and either an SPP less than 110 or heart rate greater than 100. So the HI-PEITHO catheter-directed treatment in, now this is published actually just recently, not 2006, this is 2026, catheter-directed treatment in intermediate high risk PE, 61% decreased composite, NNT 16, no excess bleeding, no intracranial hemorrhage, and it is now the reperfusion strategy of choice. We use in our hospital, we do Inari, which is thrombectomy without any thrombolysis. But in terms of the publication that is out most recently, it's the HI-PEITHO trial, which is the New England Journal of Medicine just last month. Ultima trial, this is earlier, 2014, intermediate risk, PE RV LV ratio at 24 hours, CDT plus heparin versus heparin alone. And the RV LV ratio improved to 0.88 at 24 hours. And this is patients who were included if they had an RV LV ratio greater than 1 on echocardiogram. So there was no major bleeding. This is the precursor to the HI-PEITHO. Basically, PE causes pulmonary vascular obstruction, acute RV overload, RV dilation and failure, reduced LV preload, and hemodynamic collapse. So what the CDT does is it dissolves the clot at the source. This was a small single center 59 patient study, and it justified the larger Optilyse and HI-PEITHO trials. So the Ultima was really basically why CDT works. This could have come actually before the HI-PEITHO chronologically, clearly, but it is a top 10 article because it really paved the way and shows the RV-LV ratio diminishing. Einstein PE, Amplify, and Castellucci DOACs. So let's go over that. Einstein PE, we're looking at 4,800 patients, New England Journal of Medicine 2012. We're looking at recurrent VTE. And they're basically looking at Xarelto or rivaroxaban versus low molecular weight heparin and Coumadin, and basically major bleeding. There was less major bleeding with rivaroxaban. The Amplified trial showed less major bleeding with apixaban. And then the Castellucci just has a head-to-head trial showing clinically relevant bleeding, much less with apixaban. So apixaban wins on bleeding. You should know the loading doses: 10 milligrams for 7 days for apixaban and 50 milligrams 21 days for rivaroxaban. But head-to-head, just recently published, the apixaban beats rivaroxaban in terms of bleeding, but you should know the Einstein PE and Amplify trials were the ones that put them on the map versus Coumadin. Then you have cancer VTE, which is Caravaggio, apixaban, and cancer-associated VT. DOACs beat low molecular weight heparin. So you can see here 5.6% versus 7.9%. So we're looking at apixaban. You can see recurrent VTE 5.6 versus 7.9. It's the first cancer VT trial where oral DOACs achieves superiority over low molecular weight heparin. Similar major bleeding. There was a GI tumor caution, not statistically significant overall, but higher non-major GI bleeding with apixaban in GI cancers. So we use low molecular weight heparin for high GI bleed risk tumors. And then, so cancer VTE, you should use apixaban is preferred in solid tumors, hematologic malignancies. Low molecular weight heparin still used for luminal GI active mucosal bleeding. And also this thing, years in cancer, JAMA 2026, it's a years algorithm in active cancer patients. Diagnostic failure was 1.8% versus 5%. Years safely reduces CT use even in cancer. It's now in the AHA ACC guideline. So then we have the choice, Einstein choice plus prevent. So now that we know that it was good for treatment compared to low molecular weight heparin and VK, how about when you're finished with your 6 months of, let's say, idiopathic VTE, can you lower the dose? So Einstein choice looked at 10 milligrams versus 20 milligrams versus aspirin. And you can see here there was a recurrent VTE better than aspirin. And the 10 milligram dose was essentially equal to the 20, so you might as well use the half. And the prevent trial was aspirin versus placebo. And even the aspirin showed a decreased VTE recurrence, reduced by 50%, just 100 milligrams, which is like a baby, 1 to 2 baby aspirins. So for extended anticoagulation, if you have an unprovoked PE, thrombophilia, recurrent VTE, limited duration is provoked PE, like surgery, immobility, estrogen, and the dose of rivaroxaban 10 milligrams for extended equals 20. Apixaban is the amplify extension, 80% decreased recurrence versus placebo. If anticoagulation is denied or declined, then you could use aspirin 100 milligrams via the prevent trial. Unprovoked PE extended treatment, rivaroxaban 10 milligrams, full dose efficacy, aspirin equivalent in bleeding. Aspirin reduces recurrence 50%. And you should know the duration decision, provoked 3 to 6 and unprovoked long term. And then we should definitely know about CTEP. What are the chances of getting CTEP? So this is the PENGO trial in New England Journal of Medicine 2004, and the RACE trial, which is the riociguat or Adempas in inoperable CTEP. So 3.8% at 5 years. It's not so rare. Every PE patient is at risk. Risk factors include idiopathic PE, large perfusion defect, recurrent PE. If you use riociguat in the RACE trial, increased meters, 6-minute walk, 46 meters. Post-PE syndrome, even without CTEP, there is this dyspnea, exercise intolerance, and you could do pulmonary rehab. So the CTEP workup algorithm, 3 to 6 months post-PE, get an echo. If there's an elevation in RV dysfunction, then a VQ scan. If it's suspected, the VQ scan, and then CTPA, right heart cath. If it's confirmed, then you could go to a CTEP center, see if you can get endarterectomy. If you're inoperable, then you go on Adempas. Post-PE syndrome, which is not CTEP, just doing pulmonary rehabs. So once again, PE is not cured by anticoagulation. CTEP is in 3.8%, follow with echo at 3 to 6 months. CTEP center, but if you're inoperable, Rio Sijuat. And this post-PE syndrome, which is dyspnea, exercise intolerance, even without CTEP, you go to pulmonary rehab. And then we have this new guidelines 2026, AHA, ACC categories. The A to E replace the massive, submassive, and the apixaban is the DOAC of choice. So now we have incidental P, low severity, A. B is intermediate, low risk anticoagulation, DOAC first line. So you have RV dysfunction or biomarker, but not both. But if you have RV dysfunction and biomarker, then you have intermediate high risk. And then if you have patients with RV, the LV ratio greater than 1 and distress, meaning SBP less than 110 or heart rate greater than 100, then you should get PERT and CDT. And obviously, if you have cardiopulmonary failure, E, you go to systemic lysis. So A to E categories replace massive, submassive, CDT for category D, PERT at high volume centers, echo mandatory at 3 to 6 months. Apixaban is the preferred, and the years algorithm is endorsed. So we have, again, A to E, A to C is anticoagulate, D is PERT, E is systemic lysis, and that's the story. 4 more you should know is the Optilyse. So this is 4 CDT regimens, low dose, 4 milligrams times 2 hours for similar RV to LV ratio. The clot was the initial historical trial showing low molecular weight. Heparin was better than warfarin. The years algorithm is 3 items: DVT signs, hemoptysis, PE most likely, plus D-dimer, and it was CTPA was avoided. So again, you should know the years: DVT signs, hemoptysis, and PE most likely. PERT is some PERT outcomes, and basically knowing the top 10 trials here to review: Wells and Pioped, the MAPIT-3 Constantinides. We went over the PEITHO trial, understanding the number needed to harm was actually 20 when it came to major bleeding. HI-PEITHO trial, no excess bleeding. The Ultima was the precursor to understanding why catheter-directed treatment worked. Einstein and Amplify Castellucci, understanding Caravigio, years in cancer 2026. And then Einstein choice plus prevent, showing you that extension of treatment after 6 months could be with just half dose. Amplify extension also should be in there. And Pengo and Race highlighted CTEP, and then the most recent guidelines. Thank you very much.